I call the meeting of the House Appropriations Subcommittee on Health and Human Services to order. Clerk, please take attendance.
Chair Morse.
Here.
Vice Chair Martis. Here. Representative Hood. Representative Brabeck. Here. Representative O'Neill. Representative Puri. Here. Representative Farhat. Representative Price. Here. Representative Skaggs. Here. Representative Snyder. Here. Vice Chair Green. Present. Representative Bolin. Here. Representative Meerman. Here. Representative Kuhn. Here. Representative Steele. Here. Madam Chair, you have a quorum.
Thank you, Clerk. Representative Price moves for approval of the February 22nd, 2023 minutes. Hearing no objection, the minutes are approved. Welcome, everybody, to today's meeting. We are very happy to welcome the Michigan Department of Health and Human Services Director, Elizabeth Hertel, as well as her Senior Deputy Director for Financial Operations, to provide us a presentation on the FY 2023-24 Executive Recommendation. I would ask that Director Hertel and Amy please join us. You are recognized.
Good morning. Let's see if we can get this down a little further. Good morning. Thank you. It's a pleasure to be with you today. Thank you for allowing us this opportunity to discuss the fiscal year 2024 budget recommendations for the Michigan Department of Health and Human Services, which throughout we will refer to as the MDHHS budget. As you heard in the Governor's State of the State address, this administration is focused on tackling the challenges people face right now and putting Michigan on a path to a brighter future. After working with the Governor's Office and the State Budget Office, engaging in conversations with your members, and traveling to hear what is on the minds of people across the state, our budget recommendations reflect those issues that Michigan residents care about most. Today will be one of our first discussions on the proposed budget, but it will certainly not be our last. I am joined by Amy Epke, our Senior Deputy Director of Financial Operations. Amy and Sharday Burton, who are department's Director of Legislative Affairs, will be at future committee meetings and will assist with any follow-up questions or information requests going forward. I'd also like to very briefly recognize many members of my team back here who you will also have the opportunity to meet or have met already in the coming weeks. So today's presentation will focus on three areas. First, we'll discuss a high-level overview of the department and the services that we do provide, including the impacts that the department's programs and your support of our budget have on individuals and families every single day. Next, we will preview some of the items the department is focused on for the upcoming year. These are areas that we anticipate you may hear about from stakeholders and constituents. And finally, we'll spend most of our time on the investments that were proposed in the Governor's fiscal year 2024 executive budget recommendation, including the ways in which these investments will improve health outcomes, strengthen families, make communities safer, and promote economic opportunity for individuals and families. The department's mission is to provide services and administer programs to improve the health, safety, and prosperity of the residents of Michigan. MDHHS has nearly 15,000 employees. Our projects and programs serve residents in all 83 counties and span every stage of life, from the needs of infants to older adults. Our work includes access to health care and coverage, food assistance, foster care support, behavioral health, maternal services, environmental health in collaboration with EGLE and other state agency partners, and so much more. For your constituents and people in your colleagues' districts, the statistics on this slide represent a small amount of some of the people that we interact with through MDHHS. Many of these numbers also equal families who were able to put food on the table, babies who received the nutrition they need to grow up strong, children who were able to see a dentist and a doctor, people who were able to cover the cost of basic utilities, individuals who received the care or resources that they needed to be successful, and more. This represents just a fraction of our work and the positive impact that we have on the people that we serve. While I'm very proud of what we've achieved over the past few years, we know that there is a lot of work to be done. I believe that right now we have tremendous opportunity. We still have children in need of safe home and permanent families. We have individuals in need of physical and behavioral health care services. And of course, we cannot forget about our elderly, some of whom are being cared for in nursing homes, which, like so many other organizations, are facing soaring costs. In a minute, we'll talk more about the investments that are designed to address these issues. But before I do that, I want to touch on a few items that you can expect to hear more about in the coming months. First, the public health emergency unwind. During the federal COVID-19 public health emergency, additional benefits were provided to people who receive food assistance, also known as the Supplemental Nutrition Assistance Program, SNAP, and Medicaid. For food assistance at the beginning of the COVID-19 pandemic, the federal government authorized additional food assistance to address food insecurity among residents. This extra benefit increased benefit levels to the maximum amount allowable per eligible group, regardless of income, or a minimum of $95 in additional benefits to groups that were already receiving the maximum benefit. Due to recent federal legislation, these extra benefits will end at the end of this month. They ended yesterday. Regular benefit amounts will resume beginning in March. Our department is continuing to communicate with households and through stakeholder organizations to make sure that families do have the information about this change and other available resources. For Medicaid, changes were also made to the program's eligibility, administration, and policies to ease rules for providers and to prevent beneficiaries from losing health care coverage. Michigan will soon restart our Medicaid eligibility redeterminations, as well as certain waived policies that were in place during the pandemic. The My Healthy Life Medicaid Health Plan contract rebid. My Healthy Life is an initiative to strengthen our Medicaid coverage by seeking public input as the department rebids its Medicaid health plan contracts. Through My Healthy Life, we will bring together investment, creativity, and commitment of the department and our partners, including our health plans, our providers, and our communities, to create a more equitable, coordinated, and person-centered system of care that's dedicated to ensuring people have opportunity for a healthier future. Finally, we're working to strengthen our child welfare system and moving beyond the MISEP, our consent decree. We continue to transform our child welfare system, and it has resulted in improved safety for children and families. Utilizing new strategies to target 14 areas, child safety has improved through increased monitoring of and investment in congregate care facilities where foster and juvenile justice youth are placed. In January, federal court monitors released a progress report that shows we've exceeded federal standards by keeping caseload levels lower than required, allowing workers to spend more time helping each child and family. Recent department actions that are producing results include our efforts to provide a wider array of placements to better meet the needs of each child, particularly for youth who need specialized treatment such as intensive behavioral health services. Over the last 18 months, significant investments have been made to the child welfare system that include a $25 million lump sum payment to congregate care facilities. We also call them child caring institutions, or CCIs, maybe a phrase that you're familiar with, that commit to provide services to children in fiscal year 23. Rate increases for CCIs have averaged 5% for abuse and neglect programs, 12% for juvenile justice programs, and this includes a $2 per hour direct wage increase for staff at those facilities. Improved oversight of congregate care facilities for youth, a 20% increase in rates paid to foster parents, independent living providers, relatives, and adoptive parents and guardians, and a student loan repayment program to help address the shortage of workers in the behavioral health field that has limited options available for children with mental health needs, including those in our foster care and our juvenile justice systems. Environmental health issues. Currently, concerns about Michigan's drinking water quality have challenged our public health system's capacity to investigate all chemical threats and to address environmental hazards from drinking water. For example, there are more than 60 communities out of 1,400 community water supplies with a current or a recent action level exceedance for lead or copper, and there are more than 220 sites of investigation for PFAS that impact groundwater. I really like that they spell it out for me like they think I can pronounce whatever that is. These numbers will increase over time as regulations change and water systems age. State public health investments over the past 7 years have supported some capacity to respond to emergent drinking water threats, but the level of investment in local public health has not allowed for the level of response that we think communities need. Everyone should be able to trust the water that's coming out of their faucets and the water that we give to our children. So it is essential that we be proactive and we ensure that safe drinking water quality, regardless of a household's race, ethnicity, age, gender, religion, sexual orientation, gender identity, gender expression, or disability or economic status. To carry out this directive, the department and our partners, which include the Department of Environment, Great Lakes and Energy, and our local health departments have responded to public health needs at various locations across the state, where lead has been identified in public water systems and individual residences. Over the last 4 years, the governor has worked with the legislature to reach bipartisan agreement on very impactful budgets. The fiscal year 2023 budget protects our public health and safety, expands mental health resources, strengthens our workforce and grows the economy, addresses inequity and many factors that can influence a person's health, and empowers working families and communities. The proposed fiscal year 2024 budget builds on these priorities. The recommendation for the department this year is $35.7 billion total, 6.3 billion of which would come from the general fund. This includes $35.4 billion ongoing funding and $257 million in one-time funding. The proposal includes 15,828 full-time equivalent positions. This recommendation represents a 7% change from the current year total budget and a 5.3% change from the current general fund budget. And as you can see by the chart on this slide, the recommended budget includes 72% federal funding, which is our largest source of funding in the department, followed by 18% general fund. And in many cases, as you know, the general fund within the budget allows the state to access those federal funds. The budget proposal before you focuses on 5 primary areas that include public health preparedness and response, strengthening our healthcare workforce, expanding behavioral and physical health care access and equity, investing in community-based public safety, and supporting children and families. The investments included in this budget recommendation support preventive programs, stability of services, and cost-effective approaches to meet the needs of people in large and small communities alike. The director of the Michigan, no, he does not. I did not tell him we were going to be here. But I want to talk a little bit about our safe drinking water proposal. So I think you can go to the next one. Thank you. Every person deserves safe drinking water, and in recent years, increased focus has rightfully been placed on providing safe drinking water as more has been understood on the threats to drinking water and impacts of underinvestments in that infrastructure. Currently, 75% of residents in this state receive their drinking water from those 1,400 community systems. The remaining 25% receive their drinking water from household wells. Coordination between community system operators, local health departments in the state are necessary to ensure that we have access to safe drinking water. The fiscal year 2024 recommendation includes funding within the Michigan Department of Environment, Great Lakes and Energy to assist communities with addressing their water infrastructure needs. As we all know, infrastructure improvements take time, but in the interim, filters and other short-term remedies will continue to be necessary. The budget proposal provides $100 million of one-time funding for these steps. In addition, the proposal invests $52.5 million in support, including $30 million for local health departments and $22.5 million for the department to assure community-based public health drinking water quality assurance and management plans are put in place and implemented. As I visit with healthcare organizations across the state, as I'm sure you do in here, there is one issue that comes up in every conversation: the healthcare workforce shortage. Staffing burnout and high demands have resulted in Michigan losing about 1,700 staff hospital beds in 2 years, and the direct care workforce now facing an all-time high 45% turnover rate. It's so important that we continue to do everything we can to address this challenge. So the recommendation includes investments to strengthen our healthcare workforce and to improve the state's ability to recruit new talent into healthcare professions. So there's a proposed investment of $210.1 million gross, 74.5 of which is from the general fund, to support a 10% increase in wages for direct care workers that provide Medicaid behavioral health services, care at skilled nursing facilities, community-based supports through My Choice, My Health Link, and home health programs, care at homes for the aged and adult foster care facilities, and in-home services that are funded through area agencies on aging. The average rate currently paid is around $15 per hour with some variation among programs, and this proposal would increase that average by about $1.50. Direct care workers include registered professional nurses, licensed practical nurses, competency evaluated nursing assistants, and respiratory therapists. $90 million gross, $31.7 million general fund, is proposed to increase wages for non-direct care staff employed at institutional long-term care facilities. That would include, as an example, housekeeping, maintenance, plant operations, laundry, dining room assistants, dietary workers, people who work on medical records and social services, and any other diversional therapy staff. And it would establish $5 million general fund annual scholarship program for students who pursue careers in behavioral health, counseling, psychology, psychiatric nursing, or social work. The third major category of budget investments included in the fiscal year 2024 recommendation is expanding access to healthcare and reducing healthcare costs. These investments focus on improving our Medicaid health access and equity, reforming nursing facility Medicaid rates, and expanding the Healthy Moms, Healthy Babies initiative. All Michigan mothers, babies, and families should have access to appropriate, quality, and timely care, and access to resources that help them thrive. That is why the governor introduced the Healthy Moms, Healthy Babies initiative. Women now receive 12 months of continuous postpartum Medicaid coverage to reduce postpartum morbidity and mortality in Michigan, and this includes access to doula care. The fiscal year 24 budget proposes additional funding to enhance the Healthy Moms, Healthy Babies initiative and other services or support currently available to moms and families. The initiative includes funding for Plan First to provide family planning services, expand centering pregnancy sites, remove the 5-year waiting period for children and pregnant women legally residing in Michigan before accessing Medicaid, supporting birthing hospital participation in the Michigan Alliance for Innovation on Maternal Health, or MyAIM, and enhancing our perinatal quality collaboratives. The Michigan Perinatal Quality Collaborative is part of a nationwide effort to improve health outcomes for moms and babies. It is comprised of 9 regions with the partnerships of hospitals, local health departments, health plans, and other stakeholders, whose efforts led to increased screening and treatment for perinatal substance use disorders. The governor's recommendation will increase the investment here by providing grants to local collaborations, growing their ability to coordinate to improve maternal and infant health outcomes. Occasionally, adverse outcomes in pregnancy are not related to the pregnancy itself. Michigan was an early adopter of the Alliance for Innovation in Maternal Health, which is a national initiative with a goal of ending preventable pregnancy-related maternal deaths. The MyAIM program has implemented 2 initiatives to reduce preventable maternal mortality, focusing on obstetric hemorrhage and severe hypertension. Several maternal severe maternal morbidity has decreased about 10.5% since expanding its focus to pregnancy-associated, not pregnancy-related, injury and death, and will work to improve outcomes related to racial disparities and substance use disorders. The Centering Pregnancy Care model supplements individual prenatal appointments with group sessions for moms at similar pregnancy stages. These groups create an environment for women to receive and provide community support. Mothers receiving this type of prenatal care have reduced risk of preterm births and low birth weight babies. Michigan currently has 14 sites that are certified to provide this type of prenatal care. The recommendation here provides grants to these centers to expand and strengthen their service offering. And we can get you a list of those centers if you're interested. Like other states, inequities and disparities in health outcomes in Michigan are significant, persistent, and deeply concerning. For example, Black women are nearly 3 times more likely to die as a result of pregnancy or childbirth compared to white women. At the root of these disparities are inequities in social structure, economic systems, and policies. So our department has made a commitment to take a look at our internal culture, policies, and structures, as well as how we interact with people in our communities and take action to eliminate inequity. We've updated our project bid process. Last year, thanks to the support of the legislature, we began investing in clinics and other resources for patients who have sickle cell disease. The most recent budget included outreach about uterine fibroids, which, like sickle cell disease, are also disproportionately impacting Black communities. We began requiring additional DEI training for employees, and I personally continue to travel around the state to hear directly from stakeholders, partners, and sovereign nations. Last year, I had the honor of visiting each of the 12 federally recognized tribes in Michigan, and those government-to-government conversations have really led to some important changes in our department and in our relationships with them. Like other proposals that we're presenting today, these proposals build from our current work and reflect necessary next steps. During the COVID pandemic, testing sites were utilized across the state. In many cases, these can serve as a great opportunity to transition into wellness sites that are focused on preventive measures, screening opportunities such as blood pressure checks, distribution sites for tests, and resource centers for other available resources. This proposal is designed to meet people where they are, not only in the sense of physical location and accessibility within their community, but also in the sense of their medical needs. This proposal includes a total of almost $58 million to implement the recommendations of the Racial Disparities Task Force, $2 million of which would be dedicated to develop an equity infrastructure within the department. That funding would be used to develop equity trainings within the department and to evaluate our policies and procedures through an equity lens. $2.5 million to support sickle cell services. A grant to the Sickle Cell Disease Association of America Michigan chapter will bolster their efforts providing counseling, support groups, and other assistance to individuals with sickle cell disease and to their families. $10 million to improve equity data. This funding would expand and improve data collection to support our efforts to understand and continue to address disparities in health access in Michigan. $18.1 million to create local healthy community zones. The department would provide technical assistance to support local communities as they work to create and implement comprehensive long-term strategies to address access to healthy food, affordable housing, and safety networks. And $25.3 million to create a neighborhood health grant program. That grant funding would support community-based health clinics, especially those in areas with high social vulnerability and disparity in health access and outcomes. Another component of the Healthcare Access and Equity Initiative is designed to increase stagnant reimbursement rates, expand eligibility for our children's special healthcare services, and add recuperative care benefits to the Medicaid array. This is also a common theme when I travel the state and speak directly with healthcare providers. The reimbursement rate for many Medicaid services have gone untouched for many years, while costs and commercial reimbursements for those same services have continued to increase. This has created an access to care issue. For example, Medicaid beneficiaries have trouble getting surgical procedures due to the low anesthesia reimbursement rates, which in some cases are 45% of the cost. This proposal provides funding to increase some of those stagnant rates. In addition, young adults with chronic conditions like sickle cell disease, hemophilia, and cystic fibrosis are eligible for our Children's Special Healthcare Services program. However, they lose coverage at the age of 21. Each year, there are around 1,000 young adults covered by this program. The recommendation here would include funding for young adults to keep coverage until the age of 26 under the Children's Special Healthcare Services. This would align the age requirements with the Affordable Care Act. And finally, this proposal supports assistance to those who are homeless and discharged from a hospital. In these cases, individuals often go to a shelter that is not equipped to manage their medical needs. This proposal will provide a recuperative care program supporting a smoother transition and reducing the chance of readmission to the hospital. Roughly 75% of unhoused Medicaid enrollees require access to medical services, some of which may involve hospital stays. After discharge, coordinating follow-up care can be extremely challenging, making effective treatment and healthy outcomes difficult to achieve. The recuperative care benefit, funded with an investment of $5 million, $2.2 million of which would come from the general fund, will provide these enrollees with a safe setting in which to properly recover and continue receiving care. Providing short-term transitional services will create an opportunity to connect patients with additional supports through our community mental health services, permanent housing assistance, and other services. This benefit will allow some of Michigan's most vulnerable residents to access care and receive the help they need to improve the quality of life. Michigan's nursing facility Medicaid reimbursement rates vary widely by provider, do not consider the severity of the patient, and was found in 2019 from the Office of the Auditor General report to be, quote, complicated, labor-intensive, ineffective, and inefficient. The daily rate for nursing facilities ranges from $112 to $259 per patient, and we are one of only 2 states to still use a cost-based reimbursement approach. This process is complicated and lengthy for the 450 nursing facilities we have. This proposal would provide $110 million of one-time funding to allow us to phase in a new model over 2 years. We are committed to working with the nursing facilities in the development of an updated model to provide the necessary support for individuals who need to access care in a nursing facility. The fourth category of investments are around improving community health and stability. While our communities have their own unique characteristics, and not all of us in this committee room may agree on everything, there is at least one thing that we all have in common. We want communities where we feel safe. This category of investment focuses on preventing community violence, supporting crime victims, and improving overall community health and equity. A couple of weeks ago, a short drive east of where we are sitting now, tens of thousands of people on Michigan State's campus and in the surrounding community experienced a terrifying, heartbreaking, and entirely all too often tragedy. It doesn't have to be this way. Every adult and child in Michigan should be able to leave their home, go to school or work, for a walk down the street, to eat at a restaurant, or go to the grocery store, and get home safely at the end of the day. Let's work together and with our local partners to build some of those safer communities. The fiscal year 2024 recommendation would allocate $10.8 million in general funding to develop a community violence intervention program and support 2 FTEs to help us coordinate that program. The goals will be to partner with our community-based organizations to raise awareness and develop and implement violence prevention strategies. $800,000 of general fund would be used to create the Office of Community Violence Intervention, which would distribute grants annually to community violence prevention partners. $8 million one time, half of which is general fund, would be used to provide grants to community violence prevention agencies. And $2 million, also one time, also half general fund, would be used to address injuries and fatalities related to the misuse of firearms. These grants could support efforts to distribute trigger locks and gun safety boxes to households where a child is present, education and outreach related to suicide prevention, and other gun violence prevention programs. The Michigan Department of Health and Human Services Victim Services Division receives funds from two primary funding sources, including Federal Victims of Crime Act, also known as VOCA, and the State Crime Victims Restricted Funds from conviction fees. Funds are provided to local organizations for support services to victims. This funding provides a wide array of services, including crisis intervention, emergency housing, transitional housing, counseling, legal advocacy, multidisciplinary response for child victims, and more. In 2022 alone, VOCA funded services for over 130,000 individuals in Michigan, 65% of whom were accessing victim services for the first time in 2022. Additionally, VOCA funding supported around 130,000 nights of emergency shelter, almost 97,000 nights of transitional housing to crime victims, and relocation assistance to over 6,000 individuals. In 2022, 19% of the victims who received services presented with more than one type of victimization, which requires complex and coordinated responses by our victim service providers. Both of these funds have seen fluctuations in the amount of funding received in recent years. For example, our federal VOCA funds exceeded $100 million in 2018 and are now at $40 million. Outreach has occurred to the federal delegation to encourage and advocate for additional federal funds moving forward for these very important efforts. However, in the short term, the fiscal year 2024 recommendation would include $7.9 million in general fund to help maintain these services at existing levels. We're also proposing funding to support mental health services for first responders, including support for post-traumatic stress diagnoses. The fifth and final, I said there were 5, so I'm almost done, category of budget investments are designed to support children and families. Every child deserves a safe environment where they are cared for and feel supported. The initiatives in this category help foster care families, continue to improve our juvenile justice system, and continue enhancements to the information technology system that is required for case management. Michigan relies on volunteers to provide placement for children who can no longer remain safely at home with their families. While we have been and will continue to work on programs such as day treatment and an array of other behavioral health services for kids who are in our foster care system, with the right investments, there are other things that we can do to help. When surveyed, 75% of our foster care parents indicated they ended their license due to the lack of financial support, need for respite care, having a break, and some of the other factors you see on this slide. The standard rate for foster parents is between $20 and $25 a day to care for a child, dependent on the child's age. The national average is between $22 and $26. The highest rate we have paid is $42 a day, and that is based on a child's medical conditions. This proposal would provide both a rate increase and respite care services. It would provide $19.3 million to support an average of an 8% increase for foster parents, guardians, and adoptive parents. This proposal would also invest $15.1 million to provide relief to foster parents by establishing a respite care network. Any parent or anyone who spends an extended time with a child understands the needs. Sometimes you just need a break, and our foster parents are no different. Short-term providers in this care network will receive the daily rate for supporting the child, while the primary foster care parent is able to occasionally step away for a short period of rest from what is an incredibly selfless and also incredibly challenging role. In recent years, Michigan has made improvements to our juvenile justice system, including raising the age of juvenile court jurisdiction to 18 and using needs assessments to juveniles from system involvement. Governor Whitmer signed Executive Order 2021-6, which established the Michigan Task Force on Juvenile Justice Reform. The task force was designed to implement recommendations to safely reduce placement in detention, reduce racial and ethnic disparities among kids in the system, and improve the overall system. The Child Care Fund, the primary statewide juvenile justice funding structure, does not provide financial incentives for kids to remain in the community, given that community-based and residential placements are reimbursed at the same rate of 50%. This proposal would include $31.5 million gross to increase state support for community-based services and formal alternatives to residential detention to a 75% state, 25% local. This will permit the expansion of evidence-based, community-provided juvenile justice services and better align the use of community-based and residential detention services to what is known to be best practice. While additional long-term efforts are needed on juvenile justice reform, there is a staffing shortage in our existing residential centers. The department operates 2 secure juvenile justice facilities, the Bay Pines Center in Escanaba and the Shawano Center, which is an all-male facility in Grayling. These 2 facilities have a capacity for over 70 youth with complex trauma and emotional, behavioral, and emotional needs, while also having a significantly higher staffing ratio than their peers at other secure facilities. Bay Pines and Shawano currently house 55 youth who are being supported by 71 available staff. This proposal includes $1.3 million to add 12 FTEs to Bay Pines and Shawano to align our staffing ratios and ensure safety and increasing capacity within both facilities. Right now, the department is in the process of implementing a new comprehensive child welfare information system, which we also call CWIS. This new system will help families and employees by improving our ability to effectively manage cases, including intake, investigation, and placement. In addition, the U.S. Department of Health and Human Services Administration for Children and Families published new rules in 2016 which require modifications to the case management process. CWIS is a multi-year project to replace the existing MySACWIS. CWIS includes 10 modules and will be accessed by over 7,000 users for child protective services, foster care, and adoption case management. Work began in March 2021 and is anticipated to be finished in 2026. So this proposal includes $12.6 million to support the continued planning, development, and implementation of the next phase of CWIS modules. As mentioned at the beginning of this presentation, the Department of Health and Human Services has almost 15,000 employees, and I am so proud to call myself a colleague of these individuals. We continually take on new programs and responsibilities that we know are helping and protecting families, friends, and neighbors. However, one of my greatest concerns is the capacity to support the demand for our services now and into the future. So this fiscal year 2024 proposal supports 3 key areas: adult protective services investigators who protect vulnerable adults from abuse and neglect by coordinating with mental health, public health, law enforcement, probate courts, the aging network, community groups, and the public. The Office of the Auditor General issued an audit on the APS program in 2022 and noted deficiencies in our staffing levels. So this proposal would increase staffing by 47 FTEs to address those deficiencies. This also provides support for 2 additional FTEs within the Office of Recipient Rights. That office is tasked with providing training to new community health rights staff, our hospital staff at the department, and members of rights advisory committees across the state. There are currently 22 people in that office, and over 17,000 people annually participate in trainings that are provided by us. And the office is absolutely not staffed to address this increasing demand. There were over 1,700 substantiated abuse and neglect violations and 3,500 substantiated rights violations in 2020. The FTEs proposed here will focus on creating, implementing, and updating education and training programs as required by the Mental Health Code. And thirdly, this proposal provides support for occupational health clinics at the 5 MDHHS inpatient psychiatric hospitals. Currently, our hospitals do not have an organized health department. An occupational health clinic in each hospital would provide consistency for workplace safety in accordance with MIOSHA standards. Again, as I travel around the state and listen, these represent some of the key concerns I hear for strengthening families, accessing care, workforce development, and keeping our communities safe. People are counting on us. We do not take that lightly. And we have an opportunity to once again create a budget that addresses the things people care about most in their daily lives. I also want to mention again how honored I am to work alongside all of the individuals at the Michigan Department of Health and Human Services. They dedicate their lives to their communities and their neighbors to ensure that they are living the best life that they can and have access to opportunity. And I'm so grateful for the work that they do every day. So we're really excited about these proposed investments. Again, I look forward to working with all of you, and thank you for this opportunity. I think you have a meeting schedule in place, but of course we'll be bringing in other members of our team to talk about some of these proposals in more detail. Thank you.
Thank you so much, Director Hertel. We certainly appreciate this. And I will say how many issues that are being brought to me as chair that you are already addressing in this budget, issues that are coming up over and over that we're hearing from our constituents and those people that are working out in the community. And yes, we are very grateful for your department and their commitment to making people's lives better, because if we don't have our health, certainly what do we have? So I very much appreciate your commitment to this budget. I'm going to kick us off with the questions. And my question is back to the redeterminations that are happening. I'm curious if you can sort of outline what the department is doing to get the word out. And I'm also wondering if you can address the affordability of the plans that are available in the marketplace. Can you sort of speak to, what that looks like right now as all of these people are heading out there?
I can speak to the actions that we're taking to ensure individuals are aware that redeterminations are happening. I cannot speak to plans on the exchange or in the commercial market. I'm just not familiar with that. You'd have to talk to Director Fox, who I'm sure is incredibly well-versed. We have been working with our community partners, our health plans, and others across the state to make sure that individuals are aware that these redeterminations will be starting and are aware of the options that they have if it is determined they are no longer eligible for Medicaid. And so we've been putting out notices as well as our partners through the health plans so that the beneficiaries, we are hoping, will receive those notifications and know and understand the process that is coming. We work really closely with the health plans on the notification process. One of the questions I get asked often, how do you know the address is correct? The health plans have generally more up-to-date contact information than we do, which is why we work through them as well as our own process to make sure that people are aware of what is coming. And anyone who's interacting with our local MDHHS offices is exposed to and is made aware that their eligibility redeterminations will be upcoming. Just keeping in mind that this is a 12-month process, so not everybody will be redetermined at the same time. People will be redetermined whenever they hit their anniversary date. So this will be probably a 15-month process for us to go through all of those redeterminations.
Thank you for that. Representative Green?
Thank you, Chair, and thank you, Director. So mine is quasi in that same vein, the redetermination. I can only think of my office at this point because of the issue with a different agency here not a couple weeks ago, or a couple years ago, the Unemployment Insurance Agency. So what happens, the federal funds, the extra federal funds have stopped, and so the redetermination says, are you eligible for the different programs? If we make a mistake and we say, yep, you're still eligible, but then the feds come back and say, no, they're not, what are we doing to make sure that our offices aren't getting blown up?
That's a very complex question, Representative. Thank you. First, I failed to mention, and I'm not sure what the deadline is on this, but Sharday can let you know, we will be sending a toolkit to all of your offices about redetermination so that when you do get calls, you'll have that information available. Redeterminations generally do happen on an annual basis. When the public health emergency went into effect, the federal government said, if you drop anyone from Medicaid, you will no longer get the enhanced Medicaid match, which is why states did not do that, because it was helpful to have the additional federal funding for our Medicaid population. We go through a regular audit, both at the state level with the Office of the Auditor General, as well as with CMS on redeterminations and eligibility on a regular basis. So what happens is the individual wouldn't know in real time if they were deemed eligible and weren't actually eligible. That's a process, that's an administrative process that occurs between the state and the federal government. And there are a number of things that can result in that eligibility determination between CMS and the state. Normally what we find in our audits is not that a person who was deemed eligible is actually ineligible. What we find is that they were deemed eligible for the wrong category. So sometimes there's maybe a mismatch in the amount of federal match that we're getting, but normally people are not deemed eligible when they are not. So I wouldn't be worried about that with your constituents.
Rep. Snyder.
Thank you, Madam Chair. Thank you, Director, and Amy, for your presentation today. Continuing on the redetermination process here, how many individuals will be involved in the first cohort of the redetermination process?
Our estimates for that is around 150,000 or 200,000 a month.
Okay, and then to follow up, if I may, is the department supportive of a continuous enrollment for, at least for children, and what would that look like? What would that take? Would it take legislation, some type of a waiver program, or?
Yeah, the continuous eligibility is an issue that we have discussed. I know some other states have looked at, and we absolutely would be open to having those discussions and crafting a policy that makes sense. Continuation of coverage is essential for consistent access to care, and obviously that's something we're very supportive of, so we were really open to having that discussion.
Okay, and then, so some states are covering, I've heard, the first few months of premiums for these individuals that are moving to the exchange in some way, that they're being terminated from Medicaid. What type of financial assistance would be required to make something like that happen here?
I don't know. And I'm not aware of other states that are doing that, and I'm not trying to be evasive. That's a really good question, and I would have to talk to the Department of Insurance and Financial Services because we do overlap Medicaid to the exchange. They may be more familiar with that, so we can certainly find out and get back to you.
Thank you. Appreciate it.
Rep. Skaggs.
Thank you, Chair, and thank you, Director, for your presentation. Over the weekend, many of us read a heart-wrenching article in the New York Times about the brutal exploitation of migrant children at factories who appear to be violating child labor laws. What existing state programs are there to support these uniquely vulnerable children? And in light of this crisis, what additional funding might be necessary to make sure that we're taking care of these kids?
That's a great question. This is a pretty complicated issue when it comes to unaccompanied refugee minors. unaccompanied refugee minors go into states under the authority of the federal government, the Federal Administration for Children and Families. The state government can and does provide assistance when and where it is requested of us, but the care of those children is actually entrusted to agencies that have direct contracts with the federal government. Now, some of those children do end up in our child welfare system through foster care cases based on a number of reasons. We checked, just for your own information, immediately on the number of children that we have in our foster care system who came in as unaccompanied refugee minors. We are certain that all of the children who are being cared for under state authority are not being exposed to the issues that were outlined in the New York Times. That being said, we are always available to coordinate and support the federal government, and I know that the Office of Global Michigan is working actively with ACF right now to determine when and how our services can be utilized so that we can support those kids.
Thank you for that answer. Thank you, Chair.
Rep. Price.
Thank you, Chair. Thank you, Director. My question is about another service that I believe was expanded during COVID to offer telemedicine parity with Medicaid, and recognition that that is going to be running out. And I'm curious how your department could be supported in a way that would help us continue that indefinitely.
Yeah, that, when you look back on any crisis, and you're able to identify some of the things that were really positive that came out of that, and our ability to expand, to expand the use of telemedicine, and two, for people to be open to using it, was incredible. It really sped up a process that we were hoping for. We absolutely want to continue the support and use of telemedicine, and we are actively discussing Medicaid policies to do that. One of the things that I know we have concerns about our privacy and the ability to verify, a patient is a patient, because not all telemedicine is a video face-to-face. Some of it's just over the phone. And so we continue to work with, and very closely with, the Primary Care Association, who I know has continued to advocate this to ensure that we're able to continue to offer those services to people.
Representative Meerman.
Thank you, Madam Chair. A couple of years ago, I was talking to some caseworkers in the foster care system, and they were talking about, their interface that they have to what was then the MySAQUIS program, MySAQUIS IT system. And from their end, the frustration was the time they were taking to input data, and I think probably almost everybody shares that frustration as well. And I think the parent side is up and running, and there's other parts of it rolling out, but do you know a timeline on when they'll be able to see the new SEQUIS system?
The caseworkers?
Yeah.
They're already interfacing with the first module. With the first module is licensing. There is a parent interface on that that's not 100% out there, but we will continue to roll out those modules. We're doing it piece by piece this time, as opposed to the MySAQUIS, which was done as in more of a waterfall. And getting that direct feedback and direction from our caseworkers on how to design it. So there is a group of caseworkers that is directly involved in the design of the program. So they should already be potentially interfacing with part of it. And we'll continue to do so and have the opportunity for feedback as we go through this.
My interest in that is, probably most other people's, but, freeing up some of their time just gives them time to be in front of the kids and the families.
Absolutely.
So thank you for that.
Yep. Thank you.
Rep. Hood.
Hello, thank you for your good work. Appreciation to all of the staff. Thank you, Chair, for the opportunity to ask a question. I'm curious to learn more about the community violence intervention programs. I am a champion of these programs, and we have a pilot in my community, Grand Rapids, where we have been working to advance, the distribution of new skill sets to people to handle conflict and hopefully address the gun violence issue that we have in our community. Can you share with us how you see this investment being distributed to communities? What types of partners you're seeking, what qualifications that they would need, and how those organizations who are working on a local level on community violence might strengthen partnerships with the state?
We haven't developed that level of detail yet on, what types of organizations or which, we know that we will want to take direction from local collaborations who clearly know what is best and most useful in their own communities. We've been looking at models that other states have as well to learn how they have distributed these sorts of dollars, and we'll continue to develop that as the budget process goes through so that hopefully we'll be able to implement beginning October 1st.
Rep. Bolin.
Thank you so much. Thank you for being here and the important work that your department does. It's quite overwhelming. My question is about the redetermination and exactly the cost of it, and if we're prepared to pull through. I'm hearing from people it's going to cost us an extra $20 million. So just really, how is the state prepared for that?
We have been working to prepare for this for 2 years. We knew that at some point the public health emergency was going to come to an end, and we needed to be prepared to do the redeterminations. We've invested a significant amount of the dollars that we have already into staffing and making sure that our systems, our IT systems, are going to be up to the task of the work that we're doing. We will continue to learn as we start on this. I think we feel we're fairly well prepared at this point, and we'll continue to gauge that as we go through this process. I know that some of our external partners as well are investing in resources to communicate and educate the individuals with whom they interact on this, and we'll continue to be in contact with them to make sure that we're coordinating resources and keep you apprised when we think we may need more, or as we go through this process right now, if that comes up. So I really couldn't give you a guess at this point. We just don't know. We've never had to take on this level of redetermination work ever. So we will learn as we go.
Thank you.
Thank you, Rep. Fiscal has indicated to me that the last 2 years have had funding in preparation for this. Do you know what that amount has been?
Yeah, the total amount over the last 2 years has been $30 million.
Thank you. We have 2 more questions. Currently, Rep. O'Neill.
Thank you, Madam Chair, Madam Director, and your team. Thank you for all your hard work. Just some questions regarding the community action centers throughout the state, CACs, community action centers. A lot of those organizations are, strong fabrics of our communities, as you know, urban and rural, from Saginaw County. This issue came up last year in terms of the active grant agreements, and then the recoupment process. How does that work? If they have to get, pay some of the money back or pull it down. From my understanding, correct me if I'm wrong, and maybe your staff can help address this issue, and we can maybe offline do some further deep dives, but just want to bring it to your attention that as long as there is an active grant agreement, then the recoupment would not occur. That's the information I have. Correct me if I'm wrong. If that's the case, then particularly I know the CAC in my community has been really decimated with the recoupment of funds that has prohibited them from actually retaining staff, and currently they're in a sort of a desperate situation now. So I don't know if you can talk about it now, but I would love to follow up with some of your staff directly to deal with that issue, because it's an urgent issue.
Yeah, we are aware of some of the systemic issues that caused and continue to cause some of the misunderstandings or miscommunications between some of our grantees in the department. We've worked very swiftly to remedy those and would absolutely want to talk to you specifically about what's occurring in your area so we can make sure that they have the resources that they need. You're right, the work they do is so incredibly important. Thank you.
Thank you. Thank you, Madam Chair.
Rep. Braybeck?
Thank you, Chair. I appreciate it. Thanks, Director, and to your team for all being here. Two questions. The first is, can you talk a little bit about the impacts that you've seen on your side from the reorganization? And what's working, what might not be?
The reorganization that occurred 10 years ago?
No, the one that we were briefed on, I believe, last year, like folks got changed, different departments.
Oh, internal.
Yes.
To
Yeah.
our aging and our behavioral health. And our
That's correct.
Medicaid. Sure. Yeah, it's been great, actually. So we know that internal to our department, Medicaid is a primary source of funding. Medicaid is our biggest chunk of the dollars that we get. And some of our other areas are supported more on general fund or solely on general fund. Behavioral health, while they do get some Medicaid, is, now get more Medicaid, but had historically been more general fund, and aging is some federal grants. That the staffing resources that we had available in the department weren't always at a level that we could use to support the programs that we have out there. And because we are working to make sure that people are getting the services they need when and where they need them, that coordination internally with those teams has exceeded my expectations on the ability to work together and really provide joint solutions for those different populations. So I'm really pleased at how that's come along.
That's helpful to hear. And I'd love to follow up on that too. But I have one more question, not related to this.
Okay.
One of the things that Senator Stabenow has worked really hard on is being able to have Michigan be a demonstration state for CCBHCs. One of the things that we know, the preliminary data for CCBHCs is telling us that that this is a model that works in terms of care provision for Michiganders. And I'm wondering about the continued cooperation with the department to be able to expand, our current CCBHC. We have 38 sites, 13, ones that are certified, to be able to expand that throughout our state because we're seeing such remarkable results from that program.
That's a great question. CCBHCs are an excellent example of meeting people where they are, giving people care when and where they need it, no matter what that is. The CCBHC demonstrations have absolutely provided evidence that this is one of the most effective models for care. So we have 13 sites that are in the pilot. We have 38 sites across the state. The federal government is expanding the rules to allow states who are in the pilot to just designate anybody who meets the criteria for a CCBHC to be designated as such. And we are currently working with the federal government. We just received last week from SAMHSA what some of those new guidelines are. So we're actively working to expand them per federal rules.
Yep. It's great to hear, because I know that that's one of the things that's really been on my radar just as a provider as well. And I know from talking with colleagues that who have these entities in their communities that they're working there too. So I'm excited to hear that the department is on board and there, and know that we're also trying to work with the federal government around trying to get more sustainable funding as well at their current rates. So that they don't switch as well. So thank you, Chair. I appreciate it. Thank you, Director.
Thank you, Rep. Braybeck. Seeing no further questions, I want to thank Director Hertel and her wonderful team again for your presentation, and we really look forward to having a collaborative budget process where we do as much as we can for the people of our state. And with that, seeing no further business, this meeting is adjourned.